Okay, so everyone now know by now you must all be knowing that what is peptic ulcer. It is the lesion in the lining of gastric and duodenum. Okay, and it mainly results from the imbalance between the mucosal defense factors and the acid pepsin secretion. Okay, so more acid secretion and less mucosal defense mechanism will ultimately can lead to the uh, peptic ulcer. Yes, okay. So if not treated, this peptic ulcer, this can lead to the hemorrhage, okay, then perforation, peritonitis, and even to malignant conditions. So we must treat the peptic ulcer on time. So drugs for peptic ulcer are again so they are again divided into drugs that neutralizes the gastric acid secretion, sorry, that neutralize the gastric acid, and then the drugs that reduces the gastric acid secretion, and then there is also protective agents, and okay, these are the main drugs for peptic ulcer. So in systemic uh, drugs that neutralize gastric acid in systemic, we have got the sodium bicarbonate and all other magnesium hydroxide and magnesium aluminum hydroxide that we had discussed. Okay, this antacids, they are called antacid because they neutralizes the gastric acid and increases the pH of the gastric content. So sodium carbonate, it what it does, it pro, what it reacts with the acid to produce carbon dioxide and uh, sodium chloride, right? And the main adverse effects of this sodium bicarbonate is that it causes the metabolic alkalosis, and even the sodium overload can increase the risk for the patient of heart and renal disease conditions. And sodium bicarbonate, as it produces carbon dioxide, it can causes distension, discomfort, and this belching. Okay, and uh, and also the main other adverse effects of these antacids are mainly they can rebound the acid secretion. Okay, because of increased pH will increase the gastrin secretion, and that will cause the acid secretion. And next important was the magnesium aluminum hydroxide and calcium hydroxide that we had discussed last time also. So these two drugs are mainly used in combination, okay, and they produces salt and water, that is magnesium chloride or aluminum chloride with water, okay. So this also neutralizes the acid secretion. Then there are the drugs. So before going that, again, this magnesium and hydroxide and aluminum hydroxide, they are usually given in combination. Why they are given in combination? What are the advantages? So that we had discussed last time. Can anyone describe? Okay, Roshan Kulung, are you there? Roshan is in this batch. Okay, Roshan, are you there? Okay, if not, Sumnima Limbu, are you there? You can unmute. Sumnima, are you there? Mhm.
Yes, sir.
Okay, Sumnima. So you know this magnesium hydroxide, aluminum hydroxide, they are antacid, isn't it? So what is the advantage of these combinations? Can you tell me? So last time also we had discussed, okay, the advantages of these two combination, isn't it? So if you are present, can you explain what are the advantages? One, at least one advantage of this combination. Yes.
Mm, Magnesium hydroxide and
Okay, I think the voice is not so clear from your side. Okay, so one is that it does not affect the bowel function. Okay, that is the magnesium salt. They mainly causes the diarrhea, whereas aluminium it mainly causes the constipation. Okay, similarly, there is a sustained effect of the drug. Okay, when given in combination, because magnesium it acts very fast and aluminium will acts very slow. So there will be a sustained and long time action. Okay, faster to slow action. So next is the gastric emptying is also least affected, okay, because magnesium it hastens the gastric emptying, whereas aluminium it delays the gastric emptying. And lastly, the dose of the individual is also decreased. We can decrease the dose of the individual also, okay. Now next group of drugs that we had discussed was the H2 blockers, okay. Okay, in H2 blockers, we have cimetidine, ranitidine, famotidine, and all. So this H2 blockers, the mechanism is that it mainly blocks the H2 receptors. Okay, and next that you must know is that the adverse effects of this cimetidine, okay, that mainly causes the gynecomastia, okay, gynecomastia in male and impotence in male, okay, and galactorrhea in women, okay. And there is also a drug interaction with the H2 blockers as well as the antacid, because they are going to increase the pH, so they can make a decrease in absorption of the other drugs. And cimetidine, as it inhibits the enzymes also, okay, so that will increase the concentration of other drugs, okay, like warfarin, theophylline. This along with cimetidine, there is a high chances of prolonging the action of these drugs having low therapeutic index, okay, and so there is a high chances of causing toxicity, okay, and it mainly seen with the cimetidine and not with the newer drugs like ranitidine, famotidine, roxetidine, and efetidine. So next group today we are going to discuss about the proton pump inhibitors, anticholinergic, prostaglandin analogs, then also protective agents, okay. So this is the I think picture that I had shown last time also, okay. It's the parietal cells with having muscarinic receptors, systemic receptor, and cholecystokinin receptors, and S2 blockers mainly block this as S2 receptors and inhibit the action of the histamine to activate the proton pump, okay. So there will be no hydrogen ion secretion. So you can see in this picture also, okay, this is the parietal cells and this is the stomach lumen, okay. Here the S2 receptor, cholecystokinin receptors, and S2 receptors are present, M3 receptors, I mean. So this is the intracellular mechanism that is going on, which increases when these receptors are activated, the second messengers are activated. So these second messengers will activate the proton pump. And what is proton pump? It is the enzyme hydrogen potassium ATPase enzymes which secretes the hydrogen ion into the stomach lumen. Okay. So now let's start with the proton pump inhibitors today. Okay. So proton pump inhibitors, they are the most potent suppressor of gastric secretions. Okay, and they are widely used nowadays. So they blocks the final step in acid production. Thus, they are effective in acid suppression regardless of other stimulation. Okay, so you can see in this picture. Okay, so this is the hydrogen potassium ATPase enzyme, that is a proton pump. So omeprazole will block the final step of acid secretion. So that means it can block the any stimulation of uh, um, any stimulation that causes the acid secretion, whether it's a cholinergic or gastrin or histamine. Okay, you can see here that the proton pump inhibitors, it inhibits the hydrogen potassium ATPase enzyme. So omeprazole as a prototype drug, so it is a all the proton pump inhibitors are the prodrugs. Okay, that means they form active in the body and they are acid labile. Okay, that means they are easily broken down in acid medium. Okay, so to prevent from rapid destruction of this omeprazole from this gastric lumen, okay, this omeprazole preparations or proton pump inhibitors preparations are mainly enteric coated, okay, so that they do not get destroyed by the gastric content. So the mechanism of omeprazole is that after passing through the stomach and into the intestinal lumen, that is in alkaline medium, this enteric coated will be dissolved and the prodrug is absorbed into the circulation and then goes into the parietal cell. Okay, so the prodrug, okay, when omeprazole, which is enteric coated, is taken, okay, it first goes into the intestinal lumen, and in the intestinal lumen the enteric coating dissolve, and this omeprazole is absorbed into the circulation and then goes into the parietal cell of the stomach. Okay, so what happens in this chart? You can see these proton pump inhibitors, okay, they enter into the parietal cell, the canaliculi of the parietal cell, which is the acidic medium, okay, and they get activated to form a thiophilic sulfonamide cation, okay, by the process of protonation. Okay, so the active form of omeprazole is the thiophilic sulfonamide, or the proton pump inhibitors. The active form of proton pump inhibitors is the thiophilic sulfonamide. Okay, so this active form, they binds to the hydrogen potassium ATPase in a SS group of the hydrogen potassium ATPase with a covalent bond. Okay, so covalent bonds means there is a strong bonding of proton pump inhibitors, or the active form of proton pump inhibitors, to the um, active form of proton pump inhibitors to the proton pump. Okay, that is the hydrogen potassium ATPase. So that will inactivate the enzyme irreversibly. Okay, so that means the enzyme cannot be activated again. Okay, so once there is a covalent bond, there is a strong bond in the SS group of the proton pump, and this enzyme will be inactivated. So that will decrease the acid secretion. Okay, so once again, this proton pump inhibitors, okay, once it enters to the circulation, then it goes into the parietal cells, okay, the canaliculi of the parietal cells, which is the acidic medium, and then it this proton pump inhibitors, they form to the active form, that is hyophilic sulfonamide, by the process of protonation. Okay, and this active form, they binds to the covalent, they binds to the SS group of hydrogen potassium ATPase covalently, and that will inactivate the enzyme irreversibly. Okay, so that will decrease the acid secretion. So the action of these proton pump inhibitors, they will decrease both fasting and meal stimulated acid secretion, because they block the final common pathway of acid secretion. Now the pharmacokinetics, okay, they are effective orally. Since food stimulates this, what happens is that, okay, we usually proton pump inhibitors are given at least 30 minutes to 1 hour before the meals. Okay, why? Because this food stimulates the acid secretion and also decrease the absorption of the drug. So it should be always used in a empty stomach. Okay, though the plasma half-life is 1.5 hours, but the duration of action is 24 to 48 hours. Okay, though it's have a very short half-life, but their action is very long. Why? Because of the irreversible inactivation of the proton pump. Okay, so to act the proton pump, okay, the new proton pumps has to be synthesized. Okay, so uh, the action of this omeprazole will last for 24 to 48 hours. So other are they are again highly protein bound, and they are also first metabolized, and they get metabolized in liver and excreted in urine. So adverse effects, again less, but it can cause diarrhea, headache, abdominal pain, joint pain, and rashes. Okay, and sometimes it can also cause hepatic dysfunction and chronic kidney disease. And on prolonged use, okay, it can cause osteoporosis. Okay, so that can lead to the hip, wrist, and spine fracture, and this is because of the decrease in calcium absorption. Okay, similarly, it causes hypochlorhydria because there is less acid secretion, so that can again lead to the enteric infection. Okay, so because you must be knowing that acid is also required for to kill the bacteria, but on continuous use, on the prolonged use, okay, um, it can cause the enteric infection. Okay, so that can increase the risk of hospital as well as community acquired pneumonia. And in male, it has been found to cause the gynecomastia and erectile dysfunction. These all are because of the prolonged use of proton pump inhibitors. Okay, so drug interaction is again common with the proton pump inhibitors, like that of antacid and H2 blockers. Okay, because again they are going to alter the pH, so that will decrease the absorption of the other drugs. Okay, so and affects the drug bioavailability, like ketoconazole and digoxin. And next, omeprazole inhibit the again metabolism of drugs like diazepam, phenytoin, and warfarin. Okay, and clarithromycin, which is the macrolides that inhibits the metabolism of omeprazole. Okay, so this is about mainly about the omeprazole. Now I will just go briefly about the other drugs also, like isomeprazole, which is the S isomer of the omeprazole, and it has a higher oral bioavailability with a longer plasma half-life. Okay, so it has more longer period than the omeprazole. Next is the lansoprazole. Again, it is more protein than the omeprazole, which again it has been found with lansoprazole that there is a inhibition of hydrogen potassium ATPase, which is partly reversible. Okay, and highly oral it has a higher oral bioavailability with a faster onset of action and has a longer plasma half-life than the omeprazole. Okay, and for the liver disease, the dose of this lansoprazole has to be reduced. Proton pantoprazole, which is a newer proton pump inhibitors, has similar potency and efficacy towards the omeprazole, which is more acid stable. Okay, and it has found to be less drug interaction than the omeprazole. So now uses of proton pump inhibitors. Okay, so similar to that of H2 blockers. Okay, peptic ulcer, stress ulcer, gastroesophageal ulcer, gastroesophageal reflux disease. Okay, non-ulcer dyspepsia. Okay, and others like again bleeding peptic ulcer. Okay, then S. pylori associated ulcer. Okay, and Zolingal Ellison syndrome and aspiration pneumonia. So again, the peptic ulcer, I think everyone knows this is the common site of peptic ulcer in the stomach and duodenum, that is in the lesser curvature of the stomach and first part of the duodenum. Okay, so there are various causes for the peptic ulcer, like most common is the again S. pylori, okay, which is the gram-negative bacteria, NSAIDs, non-steroidal anti-inflammatory drugs, which are mainly used for the analgesic, anti-inflammatory, and even for the for the fever. Okay, and next causes is the alcohol and smoking. So while managing the case of peptic ulcer, okay, or giving the drug, you must know what is the cause for the peptic ulcer. So first of all, we must remove that cause also, and then only we can treat the peptic ulcer. Only by just giving the um, proton pump inhibitors or H2 blockers does not cannot treat the peptic ulcer. So we must remove the cause also. So if it is the H. pylori, okay, helicobacter, the cause is because of the H. pylori, we must treat the we must kill that bacteria also. So there is a treatment regimen for the H. pylori that we'll discuss, because this is very important and frequently asked question, even in the problem based learning, even in the problem based questions. Okay, these questions is very much commonly asked. Okay, so next is NSAIDs. Okay, so if the patient is taking analgesic or NSAIDs most commonly for a very long period of time, that can also lead to peptic ulcer. So we must tell the patient to stop the and to take the NSAIDs if possible. Okay, but if we cannot take this NSAIDs, if we cannot stop this analgesic, or if we cannot stop the drug, then we must tell the patient to take the selective type of COX inhibitors. Okay, and yes, we must tell the patient to stop the alcohol and smoking. So you while in cases of in the clinical practice as well as in clinical practice, okay, if the you must always know the cause for the peptic ulcer and treat the cause also along with the managing the peptic ulcer, okay. Similarly, in the questions, based questions in your exam, during exam, okay, you might get the case with peptic ulcer, but the cause may be different. It might be a S. pylori cause, it might be a NSAIDs, or it may be a alcohol smoking. Okay, so read the problem very carefully and write the treatment. Okay, if it is a cause because of the S. pylori, you should go with the treatment with of S. pylori. If it is NSAIDs or alcohol, you must give the proton pump inhibitors and tell the patients to stop these drugs also. Okay, so yes, again, if not treated, the complications can occur with the hemorrhage, perforation, peritonitis, and malignancy. So in peptic ulcer, proton pump inhibitors, it suppresses the acid production and heals the peptic ulcer, and it has this proton pump inhibitors has become the more important component for the anti-S. pylori therapy. Okay, so S2 blockers are not preferred, only the proton pump inhibitors are preferred. Okay, and proton pump inhibitors are effective in NSAIDs induced gastric and duodenal ulcer. So the treatment or regimen for the peptic ulcer is omeprazole. It is given as a dose of 20 to 40 milligram per day for 2 to 4 weeks. Okay, that is for the duodenal ulcer. Whereas for gastric ulcer, we have to treat it for longer period of time, that is 4 to 8 weeks. Then bleeding peptic ulcer, where there is a bleeding in cases of peptic ulcer. So in that we can give the proton pump inhibitors. Okay, so usually acid enhances the clot dissolution and promoting the ulcer to bleed. Okay, so proton pump inhibitors, it suppresses the gastric acid and facilitate the clot formation and thus decreases the blood loss and rebleed. Okay, so here again in bleeding peptic ulcer, it is an emergency condition, so we have to give the drug by intravenous route. Okay, in which we can give pantoprazole. Next, in the stress ulcer, like in cases of ICU patients, okay, in cases of surgical patient, okay, or in cases of burn patient, in those conditions, there is a high chances of ulcer formation. They are called stress ulcer. So here also we can give proton pump inhibitors like pantoprazole by intravenous route. Okay, and as in S. pylori therapy, there are triple therapy and quadruple therapy in which proton pump inhibitors are the main component as a anti-S. pylori therapy. Next, in the gastroesophageal reflux disease, okay, so again, proton pump inhibitors are very much effective in gastroesophageal reflux disease, which relieves the symptoms as well as heals the esophageal lesions. And then in cases of Zollinger-Ellison syndrome, okay, it is the condition where there is a increased secretion of gastrin. Okay, so there is a gastrin producing tumor that will further increase the acid secretion. Okay, so proton pump inhibitors are given in a very long period of time. Okay, however, the definite treatment is the resection of the tumor. And proton pump inhibitors alternate to S2 blockers. Okay, proton pump inhibitors are also given for the prophylaxis of aspiration pneumonia. Okay. Now, next group of drug is the anticholinergic drug. They are less commonly used. Okay, but they also decreases the acid secretion. Okay, so pyrazipine, propanthalin, oxyphenone, they are selective towards the stomach in M1 receptors. Okay, they blocks these M1 receptors and will inhibit the acid secretion. They can be combined with the S2 blockers. Okay, and as they are very selective, so they will have a few side effects than the atropine, which is also a anticholinergic drug. Prostaglandin E analogs, in which we have got misoprostol. Okay, so this again, it acts similar to that of prostaglandin E. That's why it's a prostaglandin E analogs. Okay, the mechanism is that again, it decreases the acid and pepsin secretion, inhibit the gastrin secretion, okay, and promotes the mucus and bicarbonate secretion, and also increases the blood flow. Okay, so these are the mechanism of misoprostol, but they do not relieve the ulcer pain and recurrences. Okay, that more effective drug would be again the proton pump inhibitor. Okay, so they have got a very short duration of action. And prostaglandin E analogs are contraindicated in pregnancy because they causes the abortion. So adverse effects of this misoprostol is the diarrhea, abdominal cramps, okay, uterine bleeding, and abortion in cases of pregnancy. So it is more effective in conditions of NSAIDs-induced GI bleeding or GI ulcer, but however, the more effective is the proton pump inhibitors. Next is the ulcer protective drugs. Okay, that is the sucralfate. Okay, so sucralfate, it is a salt of sucrose complex to sulfated aluminum hydroxide. Okay, so in acidic medium, okay, this sucralfate it forms the viscous tenacious gel. Okay, and that binds to the ulcer selectively or the erosions for up to 6 hours. Okay, so this sucralfate at pH less than 4, that is in the acidic medium, it forms the gel-like structure into the selectively towards the ulcer or the erosions. Okay, and that lasts for up to 6 hours, and that will prevent further damage of the HCl or by the acid, okay, or by the pepsin. So sucralfate, it is usually administered in empty stomach, and it should not be given with the antacid, H2 blockers, or proton pump inhibitors, because what happens, the pH will increase. So that causes the decrease in formation of the gel. Okay, or the coating will not occur. Okay, that means, okay, so this sucralfate it should not be given along with the H2 blockers, proton pump inhibitors, or antacid, because they are going to increase the pH. And as you know, sucralfate it acts only when the pH is low, so that means in the acidic medium. Okay, so if the pH is high, the coating does not occur. So used in cases of peptic ulcer, bile reflux, okay, gastritis, and even in the prophylaxis in cases of stress ulcer. So adverse effects of sucralfate is it causes constipation, nausea, dry mouth, and hypophosphatemia. Similarly, the drug interaction can occur that inhibits the absorption of the other drugs, including the phenytoin, okay, digoxin, cimetidine, ketoconazole, and fluoroquinolones. Okay, so it should be given 2 hours after administration of the other drugs. So once these drugs are given, then after 2 hours only you can give the sucralfate. Next is the colloidal bismuth subsalicylate, which is also the also protective agent. Okay, so here also this colloidal bismuth it coats the ulcer and erosions at pH less than 5. Okay, so that makes a protective layer against the acid and pepsin. Okay, so see, this colloidal bismuth it helps to stimulate the prostaglandins, okay, stimulate mucus and bicarbonate secretion. Okay, and apart from that, it also helps to detach the H. pylori from the surface of the mucosa and kills the organism. So it is also used for the anti-H. pylori therapy. So used in case of gastritis, non-ulcer dyspepsia, and in cases of H. pylori associated ulcer. So adverse effects, okay, it changes the color of the stool, that is in black in color, okay, and also the tongue and teeth, and it can cause bismuth toxicity on prolonged use, causing ataxia, okay, headache, and confusion. Okay, ataxia means the lack of muscle coordination. Okay, so that was about the um, drugs for peptic ulcer. Now, the treatment of S. pylori ulcer. Okay, because this is a very common cause for the peptic ulcer. Okay, so you should know the management for the S. pylori ulcer. Okay, so because 60%, you can see the 60% of peptic ulcer are usually associated with the S. pylori. Okay, and this infection mainly leads to the impair of the production of somatostatin. Okay, and decrease the bicarbonate production and linked to the increase in acid secretion. Okay, so that will develop into gastric or duodenal ulcer and even to the gastric adenocarcinoma. So aim of this treatment is to control the acidity, spasm, okay, hypermotility for the relief of pain. Okay, and then promote the ulcer healing, prevention of the complications or reoccurrence, and eradication of H. pylori infection. So for the treatment of H. pylori ulcer, okay, there is a triple therapy and quadruple therapy. Okay, in triple therapy, there is always a presence of one proton pump inhibitors and two antimicrobials. And antimicrobials for H. pylori are the amoxicillin, clarithromycin, tetracycline, metronidazole, and tinidazole, and even the colloidal bismuth subsalicylate. Okay. So in triple therapy, there are three drugs. That's why its name is triple. Okay, and one must always be the proton pump inhibitors, and two is the antimicrobials. Whereas in quadruple therapy, it is one proton pump inhibitors with three antimicrobials. So this regimen, okay, with lansoprazole 30 milligram, amoxicillin 1000 milligram, and clarithromycin 500 milligram are the FDA approved triple regimen for the H. pylori with peptic ulcer. Okay, and all these drugs are given twice daily. Okay, twice daily for 2 weeks, so that the patient will remember to take the medicine at time. Okay, and there are other triple regimen also. Okay, instead of lansoprazole, some also use omeprazole or pantoprazole. Okay, and instead of patient who are sensitive to amoxicillin, okay, or clarithromycin, they can also go with the metronidazole and other antimicrobial drugs. And then with the quadruple therapy, okay, here the again proton pump inhibitors is given twice a day, bismuth salicylate, okay, 4 times a day, metronidazole, again 4 times a day, tetracycline 500 mg 4 times a day. That is again for 2 weeks. Or also we can give quadruple therapy as proton pump inhibitors, then amoxicillin 1 gram, clarithromycin 500 milligram, metronidazole 500 milligram, all twice a daily for 2 weeks. Okay, and you must always remember that after completing this therapy, that is for 2 weeks. Okay, both triple or quadruple therapy. Okay, patients need to be continue with the proton pump inhibitors for next 4 to 6 weeks to completely heal the ulcer. Okay, so this is how we manage the case of proton pump, peptic ulcer. Okay, so I think that much for today. This will end the class. Okay, thank you everyone.
Thank you, ma'am.